Very good morning to all. Very welcome to Brazil. I hope it's fine if we take some few minutes before the coffee. I know you are all angry for a coffee, I am. But let's take some few minutes to talk with this effervescent subject that is female obstruction. I'm sorry. In the next few minutes, we are going to talk about female urethral obstruction. But I'm going to restrict my discussion about only for patients submitted to slings. And I'm going to try to show you that the diagnosis, why it's so hard to make a diagnosis of female obstruction. And I believe it's not intuitive because we just compare women with men. And this is not the case, as I try to show you. Why is it so difficult to diagnose and establish urodynamic female obstruction? As Luis already pointed out, women rarely see each other voiding. They rarely compare directly in the infanthood by competition or contest. And voiding the standing position is rare. They don't measure each other or between voidings what is happening and what's the distance or the flow. So the flow is when we try to measure the flow by our eyes, we are flawed by that, we're cheated by that. So why does female patients in the postoperative that acquires postoperative obstruction does not complain so much? Because there is a strong cultural background of poor result in recent past. I mean, all our grandmothers cheated their children that bladder suspension operation doesn't really work well. Patients and doctors are compliant with poor clinical results. Some of the doctors that has bad results or failures for stress urinary incontinence operation, they don't really care about the patients. And more, changing doctor is a frequent issue in patients submitting or operating for stress urinary incontinence, as I will show you. We recently published this paper that is coming out in the Brazilian Journal of Urology, in where we studied 100 patients submitted to stress urinary incontinence that failed and secreted us for a different time on. And we have the opportunity not only to do urodynamic exams, but also to ask the patient why they changed the doctors, what was their diagnosis for the failure, and so on. And as you can see, many of the patients in these 100 patients, in these 100 women, they realize very early that the surgery failed. So if we take it and forget the patient that don't remember exactly or did not speak when they realized that the surgery failed, if you take this patient away, you can see clearly that most of the patients, around 20 to 40% of the cases, realized very early that the cases was a failure, that the operation did not work well. When they were asking why they changed the doctor, I mean, they went to the doctor asking for something that the surgery is not working on, that it was a failure, and you can see a different answers from the doctors regarding what was the reason for why the operation failed. Most of the doctors just closed their eyes for the patients, and these patients simply changed the doctor. When those patients were asking what happened to them, why or how they were studying regarding the type of the exams they did for the failure, you can see that about 25% only did urodynamics after the failure they were investigated. Most of these cases were investigated 4 or 5 years after they realized there were a failure after the operation. So loss of follow-up in stress urinary incontinence is a very frequent phenomenon that most of the guys do not look for. We recently published this other paper in this prospective study, we could show that most of the patients disappear from the office in the 4 years period. And they disappear from the office because they simply failed or because they are very good. So they do not show up anymore, thinking that they don't need to show up again in the office and be evaluated after a sling operation. So loss of follow-up is a very frequent phenomenon in stress urinary incontinence, as I said. And this was already studied by other doctors who already studied that. And you can see in the Leach's group, Gary Leach's group, who also studied this issue, that the patients simply disappeared, even in a prospective study, that the author trying to be in contact with these people very often, very frequently. So at this point, I left my first message. That is, the stress urinary incontinence operation has failures and complications, and regularly assumed by the doctor as success. This is not. Failure to follow these patients may be a clinical failure, and the doctors must be aware of that. So follow-up must be active on this population. This kind of phenomenon does not happen to cancer patients, as you all know. So do I need to tie this link to obtain cure? As we know that some of the patients fails for stress urinary incontinence, do I need to tie this link tight more to obtain the cure? This is a very interesting paper in the early 90s, when the sling operation was getting bold as an option to treat stress urinary incontinence. And as you can see, at that time, this author, they showed up in a very good series showing a very high rate of cure for this population, with 95% of cure for this population. But if you look closely to the discussion in the paper, the material and methods, you can see that urinary retention was very high in these patients. So the author probably is tightening too much the sling. So you can obtain cure if you tighten very much the sling, but the patient is going to be on urinary retention or obstructed. They will restart to void after a while, but they will start to void obstructively. So slinging is an operation that if you tighten so much, you can cure the patient, but you can also obstruct them. This is another paper from us in where I show in comparing 200 patients with the four corner slings from RAS and autologous sling. But these patients were followed up for 6 years almost, and the main issue here is that these patients that seems to be failing after the sling, in fact, they worsen along the time. And we are not sure about why they worsen along the time. They clinically failure along the time. To me, these patients were obstructed, and they got overactive bladder, urgency, urinary tract infection along the time, and they would start to get worse and worse and worse along the time. But as I said, and I call your attention in the first slide, most of the doctors does not pay attention to these patients. They simply accept that the patient is getting stress urinary incontinence again, or nocturia, or urinary tract infection, and they don't pay attention that those patients may be obstructed or subtly obstructed. So can we predict obstruction after sling? Well, this is a very, very good paper from 2003 with a large series of almost 400 cases submitted to TVT operations. And this paper is good because the author split the patients, the population, the studied population, on patients that experienced retention after the sling and those that did not experience a retention after the sling. And as you can see, age parity hysterectomy in Qmax was showed a p-value, significant p-value. So age parity hysterectomy in Qmax was determinant to predict if the patient was going to be on urinary retention after the sling or not. But more than that, when multivariate analysis was used, only peak flow rate was determined to reveal if the patient is going to be on urinary retention after TVT or not. And so we can say that as long as you have a low flow rate before the operation in the pressure flow studies or not, you have the higher rate for urinary retention or not. So it's easier to put a patient on urinary retention after a sling if they already void with low flow rate before the operation. So doing urodynamic studies is a very good thing to do before this operation, because we are in a mood to try to stop doing urodynamic exams for this kind of patients. So be aware of that. And more than that, in the same study, the authors also studied the percentage of patients that got urinary retention or not after TVT. And they showed up that patients got a higher satisfaction, a higher clinical outcome and quality of life after the operation if they got no retention compared for those that got retention. Taking back my first attempt to understand why some patients get worse and worse along the time during the long follow-up on those patients who made to any kind of sling operation. So where does the obstruction comes from? As I said, you can tighten this sling and really put the patient on urinary retention. Well, sir, the obstruction comes from the surgeon. This is a very personal data that we recently published too in 2012, showing my own experience with autologous sling in almost 156 cases submit to autologous sling. And as you can see, when I was a junior urologist, my rate of obstruction was much higher when now I have a gray hair. So it's important to understand and to learn how to treat these patients and do the operation well. More than that, if you compare the patients submit in my early experience, the first year of my early experience with a sling, after 4 years on doing the slings, you can see clearly that as long as you got experience, you are more seasoned on this operation, you have a lower rate of obstruction. So the surgical experience and the surgeon itself are the main factor to impose obstruction on these patients. As you can see in the same population, you can clearly see that obstruction, that sling, even for those that has a very good clinical outcome, a very good clinical result, they have a little shift from the non-obstructive area of the nomogram to the obstructive area of the nomogram. So slings are obstructive, and they work as obstructive to have a good result. This is another very interesting paper derived and extracted from the Thomas, which enrolled almost 600 cases in the United States. But I will restrict my discussion only for the arm that compares sling operation. The authors here analyze patients in the baseline with urodynamic studies and also 24 months after the sling operation, the autologous sling in this case. And as you can see, the baseline compared to 24 months of follow-up, you can clearly see that Qmax, residual Qmax during the pressure flow, or the detrusor pressure at Qmax are always shifting from the non-obstructive to the obstructive area of the nomogram, showing that the sling, despite being good results or not are obstructive. And it doesn't matter it is obstructive. It has to be not too much obstructive, because if it is too much obstructive, symptoms will overcome. If only a bit, you can have a good success on this, but not become urinary retention or obstructive voiding as you wish. If you compare again the detrusor pressure, the Qmax on this population, you can also see differently from the other paper. Yes?
Maybe you could tell us what you learned in those 4 years, your outcomes.
Yeah, I'll show you in the next slides. And this paper, differently from the other paper I showed you, the Qmax, the detrusor pressure at Qmax was the most determinant in regarding if the patient had a success or a failure. This other paper that we published in 2011 showed clearly that most of the girls or the women that was submitted to stress urinary incontinence, in this case urethral slings with the TVT, they were cured for stress urinary incontinence. Well, at this time I had already almost 15 years doing slings, so I got 100% of stress urinary incontinence cure rate. But as you can see, during the 3 and 6 months, you got a lot of void and dysfunctions after the sling that tends to disappear along the side, along the time. So it's natural, and maybe sometimes it's a little bit obstructive, but some of the symptoms seems to vanish away along the time. So stress urinary incontinence is curable by TVT or any other kind of sling when well done. Void and dysfunction may appear in the early months, but tend to vanish along the time. If it persists, probably there is an obstruction. So my message is sling is a very good operation to treat stress urinary incontinence. If well done, it only restores the backboard of the urethra, and it's not obstructive. So the cure rate is around 100%. If badly done, it is obstructive. But if it's badly done, may lead patients to urinary retention. So be aware how tight you tighten the sling. So having said that, my second message is sling is certainly obstructive or tend to be obstructive, but they don't have to. You have to acquire the expertise to put the sling in the appropriate place and with the appropriate tightness before you have a good clinical. And it demands a learning curve. I mean, no matter what, you have your own learning curve. And in understanding how it works promotes a successful surgery and high rates of cure for stress urinary incontinence, as I showed in my own experience. Well, Paulo, what about urodynamic diagnosis? As Luis already pointed out also, there are two extremes, hypocontractility and shortness of contraction, that we are calling now obstruction and underactivity. So both can and coexist as a broader concept of void and dysfunction. But female obstruction may be subtle, may be associated with the stress urinary incontinence cure, and still exists a female obstruction. And it may be clinically relevant, the female obstruction, but urodynamically not diagnostic. And why not? Because we have 3 parameters that determine how the bladder empties: the detrusor strength, the duration of the contraction, the cross-sectional area of the urethra. And we can analyze every one of this as I show you. The detrusor strength, we learn from the BPH patient, does not vary. The preoperative and the postoperative period does not vary. I mean, the energy disposable to empty the bladder, to become flow, does not vary if there is a high resistance or a low resistance. So when you do a TURP, you are not you are only relieving the obstruction, you are lowering the resistance, but the detrusor pressure, the amount of energy to translate from the potential energy to kinetic energy does not change. The cross-sectional area of the urethra. If you look at the bladder and understand the bladder as a unique mill, as unique motor, the flow depends on the cross-sectional area of the urethra. So to the same detrusor pressure, the flow will varies depending on the cross-sectional area. Because if you have a high or a large cross-sectional area, the flow will be larger. But it will be larger measured by distance. And the great flaw here is that when you look at the flow, you cannot really understand what's the volume that is going into the flow. So the eye has a flaw to understand and to measure what's the flow. That's why we make so many mistakes, or the patients make so many mistakes concerning the comparison between the preoperative flow and the postoperative flow. The eye cannot measure this correctly. So can I measure the flow and put a filter to do urodynamic exams in these patients if I do a free flow rate? This is a very interesting paper too, in where the authors compare patients with stress urinary incontinence, overactive bladder, and healthy students or middle-aged women. And as you can see, the bell shaping that is considered to be a normal flow curve does not vary among the population. So we cannot distinguish these patients only looking for the free flow. It's not correct. So the eye does not measure the flow correctly, not even the shape. So why diagnosing bladder outlet obstruction in women so important? Because the quality of life and the way the women look into the result of the operation varies according to the presence of urgency, or if it's urgency is present or not in the pre and postoperative period. I mean, if you do a sling and the patient got just a little bit tightened and they got obstructed, they will probably develop an urgency or urinary tract infection or de novo urgency or obstruction or residual or something else. And this will impact in the way the patient perform and the way the patient feels as a failure or as a cure for stress urinary incontinence when measured by visual scale. So avoiding getting urgency after sling operation is tantamount. So after a sling, if you do a very good sling, you can have a normal void and very, very few symptoms or no symptoms at all. But if you tighten just a little bit and you obstruct the urethra trying to cure the patient, the symptoms, the voiding dysfunction will overcome. And it will overcome so hardly that urinary retention can appear. I mean, urinary retention is the extreme of a wide range of situations that comes from no symptoms, no obstruction, until urinary retention. And the same is for the urinary flow rate, as I already showed. So we have a balance here between urinary flow rate that the women cannot measure properly, and urinary retention and as the end of the symptoms. So if the patient has no symptoms after a sling, it's easy to see that. And if the patient has urinary retention in the other extreme, it's also easy. You have to do something. You have to go back to the operation room and cut the sling. But the problem is what to do in the patients in the middle that complains of something that complains that the urinary void changed after the operation, but you cannot show that there is an obstruction. Should we progress to urodynamics in light of clinical evidence? I'm sure yes. If you suspect of female obstruction, it probably is. I would say it certainly is an obstruction. So the most important thing or parameter related to female obstruction is the relationship between the event of the operation and the onset of the symptoms. So if something happened after the sling, it's probably related to the sling, and it's probably an obstructive urethra. And it's much better if you have urodynamics to compare the preoperative period and the postoperative period. So I don't think I'm very permissive in doing urodynamic exams for stress urinary incontinence patients to be submitted to surgeries, because there is no relationship between symptoms and the grade of urodynamic obstruction. There is no relationship between grade of obstruction and the final clinical results of the cure or not. And only about 40% of women present the trusor overactivity after obstructive sling. So it's difficult to diagnose obstruction. But if the onset of the symptoms start just after the operation, there is something else. And it demands a high suspicion and a high intuition from the doctor to assume that, because the symptoms of obstruction can or not be present, as well as the recurrency of the urinary tract infection, as well as bladder neck deformation seen at the image exams, or even post-void residual. So it's hard to diagnose this kind of patients. Luis pointed out very, very well that the Blaivas-Groutz nomogram has a lot of flaws. And the main flaw from this paper, or from this nomogram, is that the authors compare the free flow rate with the detrusor pressure measured after catheterization. And in this very, very recent paper that is coming up at the Neurology and Urodynamic, you can see that the non-instrumented flow compared to the pressure flow study, the flow obtained after the urethral was catheterized, vary dramatically if the volume inside of the bladder is around 200 or 700 ml, meaning that you can change the areas on the obstructive or not obstructive area in the nomogram's flow. So it's amazing how Blaivas did such a mistake when concepting the Blaivas nomograms, the Blaivas-Groutz nomograms. And that's the main reason why it's so difficult to put patients and establish female obstruction in this kind of nomogram. It doesn't work that simple. So my proposal is that widening the concept and widen the mind to understand obstruction in females with a different view. As you can see in this large series from Petri, the most frequent reason for patients coming back to operations after the sling is for obstruction, dysuria, wrong placement of the sling, and so on. So obstruction after the sling is a real entity and must be viewed like that. What we did in recent paper in 2012 is that we got 283 patients, consecutive patients, complaining of obstruction that present to our urodynamic unit. But 232 patients, 80% of those cases, start to complain of obstruction just after an operation. And what we saw is that this kind of complaints, urgency, frequency, recurrent urinary tract infection, uricturia, was the leading complaints in this population. I mean, 80% of the patients that complains of something after the sling or after a bladder suspension complains of something related to empty or voiding dysfunction. And what we could conceptualize is to divide these patients in five patterns of obstruction, because I know something is happening in the urethra of these patients. So To my mind, all of them, all the 230 patients were obstructed, and they acquired the obstruction after the operation. So we could divide these 4 patterns, and as you can see, the low flow, high pressure pattern, which is the main pattern in male, accounts for only almost 10% of the cases. The second pattern, which is high flow and high detrusor pressure, which is also obstructed, demands for almost 50% of the cases. The third pattern that encompasses 25% of the cases are those patients that had normal flow and normal pressure, but they have an extended period to empty the bladder. So they are obstructed, but they have normal flow and normal pressure. The fourth pattern, compressing about 30% of the cases, are those that had low flow, normal detrusor pressure, around 20 centimeters of water, but they have a high residue. So these people are also obstructed. And the fifth and last pattern that encompasses about 15% of the cases, they void by straining. So these patients, all of them are obstructed if you want to, but they have different patterns, and only the first one would be considered obstructed if you compare males to females. So it's a different kind of conceptualization to understand why and how female obstruction works. If you see this in a different manner, in different words, you can see those parameters, the median of these parameters. So in resume, you can see that pattern 1, the most important finding is the high pressure. It's easy to put this patient as obstructed. The pattern 2 is the Qmax that is very low, about 6 ml. The pattern 3, the time extended to empty the bladder. The pattern 4, the residual is very high, more than 150 ml in subsequent voidance in the same session. And pattern 5, the main finding is the straining to void. So, having said that, I left my third and I think my last message. The female pattern of outlet obstruction is very complex and does not obey a single relationship as the pressure flow as in men. It's more complex. Thank you very much for your attention. I will be glad to clarify any other question if you want to. Can be at this time or just after the coffee break or in the corner of the room if you want to. Thank you very much.
Can I make one remark? I unfortunately
Yes, sure.
cannot attend the second part of it. First, we listen to our voiding. So we know if our flow is strong or not. So we listen to each other. No, you are not allowed in our rooms. I just tell you. So if we have toilets with small walls, we listen to each other and say, oh, that's good or that's not. So we are used to listen, perhaps because of our profession, I don't know. But that's one point. The other one is you say you're open-minded. So I will give you some remarks to perhaps you can think about. If women are in pain in this area, they contract their pelvic floor. Mm-hmm. And if you contract your pelvic floor, you are inhibiting your detrusor muscle.
For sure.
So if you have dyspareunia and pain, what the women often have after the surgery, they cannot relax their pelvic floor and they try to strain to get it out. So this is, again, the pelvic floor musculature that you really need to involve in your new plans, and because this is a very important topic. But if women are in pain, there is no good circulation and they are really having a lot of issues there. And the sooner they, in the part you can say we can't solve it on mixing patterns, please look at the pelvic floor musculature and send them to a physio. They can learn how to pee correctly and relax their pelvic floor to regain their normal synergy in peeing.
Okay, thank you very much
Just-
for your remarks.
Thank you for your nice talk, and I think you very much focused on obstruction, and I agree that probably in females most obstruction are yet done by the doctor themselves. But how about contractility? Because the way people void afterwards might have to do with contractility in the first place. And of course, obstruction is already difficult to define. I think I find it much harder to define contractility, and I think it's a myth to concentrate only on the detrusor pressure to define contractility, whereas when I see your first slides, maybe the relaxed voiding, possibly without or with little straining, the flow is probably more representative of the contractility than the detrusor it is. Because I find it some certain, also in the papers, I say, you know, that they say failure of TVT or suburethral sling comes with low detrusor pressure. But I think a lot of the detrusor pressure, we see a lot of women with very low detrusor pressure because they have a wide opening, so they don't, that's not something which comes per se.
That's correct. In fact, even treating patients with BPH, I was always wondering why patients that shows up at the emergency room in urinary retention does not come before the urinary retention. So the detrusor contractility varies very much along the population. So some of the patients can void efficiently with very low detrusor pressure, and this is more markedly important in females than in males. But most of these patients are asymptomatic or clinically irrelevant. So the detrusor is like a signature. People can empty their bladder very efficiently, and they will only be on urinary retention after you do something in the urethra.
Yes. But the one thing is of looking up intravesical obstruction after she has done her surgery. But the other thing which is needed is a tool to evaluate. I have a lot of elderly people in my practice. So what I want to know is does she have a contractility sufficient to overcome maybe even a minor obstruction, or a minor obstruction which wouldn't make any difference for younger patients might be a difference for her. And I think if we look on nomograms, we have to look on the obstruction side and also how we can define contractility.
Yeah. Okay.
Okay, we'll address the options. Oh, you have a question? Paulo?
Yes, I just have a quick question regarding follow-up. We know that most patients after a sling do well. So do you follow up everybody for how long and how often? And which ones are the ones you think are at risk for having problems which should be followed up more carefully?
Well, I know that the individual practice vary along all around the world, and 100% of these cases are from my private practice, so I don't discharge these patients forever. I always say you have to come back once a year for the rest of her life, because some of these patients got a TVT, they got meshes. So I want to examine these patients at least once a year. So the mesh position, the obstructive voiding dysfunctions, and everything that is related after operation must be evaluated at least once a year, because as long as you put a mesh, this patient cannot be discharged forever. That's what I think.
Okay, again. So after the break, we'll try to see how can we overcome all this mass with some interest to our clinical practice.